So my name is Ari Vanderwalde. I'm a medical oncologist, and I am the Director of Clinical Research at West Cancer Center and Research Institute in Memphis, Tennessee. I'm also the Associate Vice Chancellor for Clinical Trials at the University of Tennessee Health Science Center. I particularly treat melanoma and its associated complications. So immune compromise means that your immune system is not working the way that it usually would be working. That doesn't necessarily mean that it is not working well enough, and it doesn't mean that it's not working too well. It just means that something has happened that makes it so that your immune system, which is usually there to fight disease and to recognize the difference between your own body and invading organisms or invading cancer cells, has been somehow lessened. This is commonly the case in people with cancer who are undergoing active treatment. It can also be the case in anybody who has chronic diseases. People with a history of cancer might be a little bit immune compromised, although it's not evident from regular blood checks. So I first want to start by answering that question of what the risks are and what the additional risks are with COVID-19 and cancer by stating categorically that we really don't know the answer to these questions. This is happening very quickly, as everybody in the audience should know. And we're learning new things every day. The usual scientific process of vetting the data has been somewhat curtailed, made a little bit harder to do. So any answers that I give here, I just want to be really clear, are changing day by day, and there is no right answer or wrong answer here. Does a risk of cancer count as a chronic disease is to some extent the question that is being asked. We know that people who have a history of chronic diseases like heart disease or lung disease do have an increased risk of having bad complications of COVID. The answer as to whether or not cancer patients have, or people who have a history of cancer have an increased risk of bad complications of COVID is still not entirely clear. There have been a couple of studies out of China and a couple of new studies out of the US that say that the risk of complications can be a little bit higher in people with a history of cancer, but some of that is muddled by patients with active cancer. And those patients, it's not clear whether or not their increased risk of severe disease has to do with the disease itself or increased utilization and access of the healthcare system when they're getting active cancer treatment. So oral cancer therapies are a broad range of different types of therapies. Some oral cancer therapies are chemotherapy and can cause immune compromise. Others are hormonal therapy or targeted therapy that don't cause those traditional side effects of causing the immune compromise that we talked about before. The general rule about oral therapies is that because the therapies can be administered by the patient at home, the utilization of the healthcare apparatus is a little bit less, which is a fancy way of saying you don't have to go see your doctor as often, and more of your doctor visits can potentially be done online via virtual meetings. So the general approach to oral cancer therapy is that it should absolutely continue, that people should not put off their cancer therapy, and that they should try to do their visits with their doctors via the internet whenever possible. So that's a very good question, and the answer, of course, is very nuanced. It really depends on why you're starting systemic cancer therapy. Patients who have metastatic cancer, which is not curable cancer, almost ironically should not put off their cancer therapy at the current time because the disease is actively growing and you want to be able to start therapy in a relatively short process. And so the risk of getting COVID or the risk of transmitting COVID at the healthcare setting is actually actually offset by the potential benefit that can happen when you start chemotherapy. Where the question really arises is in cases where the cancer has been entirely removed from a person and they're going to be starting chemotherapy just to kind of mop up any residual cancer that might be there. And that type of cancer therapy can potentially be put off It shouldn't be skipped altogether, but it can potentially be put off for as long as 10 to 12 weeks after the surgery is performed. So that's something to discuss with your physician to see whether if you have early cancer and that systemic therapy is warranted off, excuse me. Now, cancer therapy that I'm talking about is systemic therapy, usually IV therapy. Talking about therapy like surgery or radiation is a very different story. I'm not a surgeon, so I don't want to be able to answer that question for the surgeons, but I think it's an important conversation to have with your cancer surgeon or with your cancer radiation oncologist as well, because different considerations might apply. So the question of whether or not to continue getting tested to see whether or not you are having recurrence really depends on how often you're getting tested and what the comfort level of your physician is to decrease the frequency of testing that you're getting. Generally speaking, people who have their cancer completely removed can probably go down at the current time from every 3 months testing to every 6 month testing, depending on the risk factors. Generally speaking, it's a conversation to have with your doctor as to how comfortable they feel and how comfortable you feel with delaying the amount of time between tests. There isn't a right answer and a wrong answer to this question. It really is patient-specific and doctor-specific, but it is a conversation worth having with your physician to see if that can actually be pushed off a little bit.